Hello and welcome back to Authentically Shawna. I'm your host, Dr. Shawna Burke. Welcome to 2025. I am so excited to have a guest with me on today's episode. His name is Dr. Taylor Sillekens. He was a classmate of mine in graduate school and my literal ride or die. When people say the word ride or die, Taylor's face instantly pops into my head because Taylor would come and pick me up and drive me to grad school. And yeah,
Those are good times.
yeah, that was like the best stress relief that I could have ever asked for was Taylor picking me up and us just jamming out in your car.
Yeah, playing R&B just because the day was going to be so long.
We knew it was going to be rough.
Yeah,
And we just, yeah,
smooth, music before we got into the rough day. So
yeah.
good time.
That was the best way to start grad school was with Taylor. So thank you for being my literal ride or die.
It's my pleasure.
So Taylor has accomplished a lot since we graduated in 2021 and has expanded his universe of physical therapy in a way that I haven't. So I wanted to bring him on the podcast to talk about the things that he has learned and how that shaped him as a clinician. So Taylor is a physical therapist, so a doctor of physical therapy. So behind his name are the words DPT. Then he did a certification, which you take a big test for, which we'll talk about for OCS. And then he also has CSCS. So when you look at his names, there are lots of letters behind it. So we're going to, alphabet soup. We're going to break down the alphabet soup. So one thing that I really wanted to ask Taylor is what do you think a physical therapist is and what do they do?
Yeah, I mean, just to keep it very simple, something I think we've been told a lot now is, primarily we're movement specialists. I mean, just to dive a little bit deeper, we look at things from a big standpoint. One of the biggest things I like to still use is like the ICF model. So, we don't just treat the condition, we're treating the person. We're people that work with people on multiple levels, not just movement, but obviously that's primarily what our degree is in, right? But we look at personal context, we look at environmental context, your situation at home and how your condition may be relating to your activities, your movement. That's maybe walking, or maybe it's using the stairs. Maybe it's just standing up from a seated position, things like that. We see how that affects you and how that affects your everyday life, your roles maybe as a father, a mother, brother, sister. And we do our best to work through a movement standpoint. But again, it's much more than just movement. And movement is really complicated too, right? So people may think, oh, just throw people on a bike or, have them do exercise. But no, there's a lot of neuromuscular things that we do.
Let's talk about that.
Okay.
Let's talk about neuromuscular. Can you tell us what that means?
Yeah. So just to keep it's a very complicated subject.
It's super complicated.
Just to keep it, maybe layman's a little bit.
Yes, please.
It's the mind-body control, right? So our muscles can't move without connections from ultimately our central nervous system, which, starts with your brain, spinal cord. You have nerves coming down, ultimately, you have motor units, and then that helps move our muscles, things like that. And so because that system's so long and, pretty much complicated, there's so many things that can go wrong from multiple standpoints. Peripheral means something that's a bit further away from your brain and spinal cord. Central means, your brain and your spinal cord. So things can go wrong peripherally or centrally. And I think, where people don't understand what we do is we also work with the central part of things too, where it's not just the peripheral, your typical, your muscles, your ligaments, your bones, your tendons, whatever it is. It's also sometimes retraining your brain to be able to connect better with your body and teach it how to move in totality. Movements are really complicated. You may think that walking is just walking, but, when you break down walking, you have your initial contact, you have your loading phase, you have your mid stance. You could divide mid stance into two. You could do terminal stance, pre-swing, initial swing, mid swing, and terminal swing, right? Like that's just a
one step.
And then if you look at that, then that's broken down in like 25. Each of those are broken down into like 25 different steps, right? And so it's crazy. And it's really cool to know that, we have that space to work on things on such a complex level. But I think that's what sometimes people, misunderstand is that, movement is really complicated. And it's affected not only just from that neuromuscular point that I was talking about with the mind-body connection and the muscles, a bit more orthopedic, if you will, but your survival systems, in school, shout out to Dr. Spina talking about, survival and thrival systems and things like that. But, your cardiovascular system, right? Your heart and your lungs, and shout out J-Rod too, right? Love J-Rod. If those systems aren't working, like, good luck trying to get, your neuromuscular and your orthopedic systems working. So we have to take all that consideration and all that to say that, we have doctors, we have that doctor title in front of our name for a reason, because we're not just personal trainers. We're not just massage therapists. We're people that work with the body on so many different body systems just to make it so that you can stand up and walk and do all those things better. So yeah, hopefully I did that justice.
Oh, that was so brilliantly said. Thank you. I feel like you captured that so well. So we're going to dive more into one of the things you said, which was orthopedics. So in physical therapy, there are separate subcategories that you can delve even further into. So when we get our doctorate in physical therapy, we're general specialists in everything.
Mm-hmm.
We've taken classes in cardiovascular, in pediatrics, in orthopedics, in neuro, in what am I forgetting? Geriatrics. I already say that.
Yeah, sports, geriatrics, neuromuscular, cardiopulmonary, and integumentary wound care.
Yes.
That one threw me for a loop. I'm not gonna lie. I was getting the physical therapy. I did not know that was a specialty.
Yeah. Yeah.
Oncology is growing.
Yeah.
Women's health, but now I think it's generally just
pelvic. Yeah.
health, which I know I'm not even gonna talk to you about that. You have a lot of experience in that. With all the stuff you've done. But yeah, I mean, there's ultimately, again, like how I talked about, the body is so complicated and we have to know things from multiple systems. So essentially, we have a specialty in every system and see, we specialize to use that system to move better at the end of the day, right?
Right.
But again, it's just more than movement, obviously. That's where we go to the most. But that's why we have those specialties, is because, yeah, your pelvic floor is going to be related to,
your low back, your knee.
A huge referral area.
Yeah.
Right? We're talking about orthopedics a little bit. That's one thing that, might dive into a little bit right now, the orthopedic. I have different frameworks and stuff that I treat through. One of the main things is, I think across any orthopedic specialty, you have to be really good about screening, right? And that's the first step is, you have to screen, are we going to treat, we're going to refer, are we going to treat and refer, right? A lot of times it ends up being treat or refer. Hardly ever do we, unless it's emergent, right? And you have those hard red flags, do we just refer, which sometimes you do, right?
Yeah.
And we could kind of dive into that later, but yeah, it's screening and, it's knowing those things. So red flags, let's dive into red flags a little bit, right? That might be you have low back pain and somebody comes in and mechanically you screen and you're like, okay, hold up. Your lumbar range of motion is really good. Doesn't bring on pain. You could do MRTs, you could do whatever special tests you feel like you want to do. And for whatever reason, it's just not bringing on the pain. But you're like, well, tell me about your bowel and bladders. How are those moving? Or do you have any sexual dysfunction? You're like, well, lately it's been hard to, urinate, or, I've had problems with my bowel movements, or, it's been hard, even just having sex with my husband or my wife or whoever it is. Like, that's been hard. And, that we all know, like with the pelvic floor, that is going to refer pain to the low back most of the time, right?
Yes.
And obviously around the groin area and things like that. So as an orthopedic specialist, you have to understand much more than just orthopedics, knowing that, like, okay, somebody may come in with like emergent left shoulder pain, but like no mechanical, everything's good. And then you talk to them like, oh yeah, I was in a football game and somebody hit me in my left upper quadrant. Like, oh, maybe their spleen is ruptured, right? Which is sideline stuff too, something we'll later. But you got to know all that. And I think that's the biggest thing that maybe also people don't understand, but that also is specialized, a lot too. And we know that as obviously as general practitioners, but
right.
You get hammered a little bit more of that orthopedic specialty, understand like, okay, really do red flag screening. And I'm talking about that test. So I'll dive into it, explain it for the listener.
Please.
So OCS, that's one of the letters,
the three.
Those are three behind my name, because it's a PT, DPT. PT means you're a licensed physical therapist. DPT means you graduated from a Doctorate of physical therapy program. And then the letter after that's OCS, Orthopedic Clinical Specialty, as provided by the American Board of Physical Therapy Specialties. And yeah, so you can do that a multitude of different ways. The primary two pathways are going to be going through a residency, which, that's not my path, but I still recommend that. It's a very good path to do. At the point in my life, it wasn't something that I wanted to do, going back into residency after having worked for a little bit in a situation where I'm at. It just made sense for me to do independent study, which
you're really good at. You're really good at it. I'm going to say you're really good at.
Yeah, it's definitely my learning style to study a bit more independently, for sure. But yeah, so independent study, which is a lot of work. If anybody listening has any questions about that, and I don't cover well enough on this podcast, feel free to reach out and I can tell you what that entails. But, just a little bit, I try not to digress too much, but a little bit.
No, please.
I'm working all day, at an orthopedic clinic, sports clinic as well. And I come home and I'm studying, right? And the weekends, my friends are like, hey, let's watch football. I'm like, you gotta study, right? And so, everybody has their studying time frames, but you're gonna study for a few months at least. Some people over a year. I probably did it over strong, probably around like 5 to 6 months, just cracking down, making sure I could really do good. Because, when you do a residency, it's going to prepare you a lot better than independent study. Like I forget the stats, but Michael, Dr. Miller, shout out Michael too. I think he had the stats of like it being much better in terms of the passing rate going through residency. So again, a recommendation for me. But if you don't, studying a lot, current concepts.
Yeah, let's talk about that. I want to talk about current concepts.
Cool.
Go for it.
Yeah, current concepts. Hope I can do it.
That's one of the things that I feel like in grad school we did not get educated on very well. I feel like that's so important. I was like, how did we miss this?
Yeah.
Who missed that?
No, it's hard, and I love our program, but there are certain times I'm like, okay, like things could have been a little bit different in terms of
skew differently, timing,
and certain orthopedic things probably could have been a little bit more up to date, but again, just a great time. Yeah, current concepts. I don't want to do this do it a disservice, but
just like generally what is how do we use it as clinicians?
Absolutely. So you can access this through the APTA website. It is an additional fee, I think. So there are different monograms. So primarily there are monograms that talk about each current research and what the most current research is saying about each like body part. So there'll be a monogram on like, okay, thoracic region, monogram on lumbar region, and it'll compile all the best systematic reviews, even what they have like the expert clinicians writing these. So, what they feel like works, they tie in CPRs, which you could talk about.
Yeah, we'll talk about that as well. Yeah.
And they try to give you the best, most updated way on how to view the region, how to screen it, how to examine it, and how to intervene with it. It's a pretty comprehensive monogram, and they give you the main current concepts book that will give you, I forget how many monograms, but a monogram per body region, which again is going to be like your cervical, your thoracic, your shoulder, your lumbar, hips, pelvic as well, knees, ankle, foot might be together, elbow, wrist might also be together. So it's just a good way to stay up to date. And for me, I've done it, and obviously it was motivation to do that for the test because it prepares you well for the orthopedic clinical specialty exam. Which is very debatable. Some people are like, oh, no, I didn't like it. I felt like it prepared me well for it.
Oh, good.
So, well, we could talk about that later. But yeah, it's good for that. And as long as I'm still a clinician, I'm always going to try to read that book. Even with, maintaining my OCS, I think it's very important to still stay on top of it. And I think, diving into this, because for me, at least, everybody's like, okay, yeah, I'm an evidence-based practice PT, but like, how are you staying evidence-based practice, right? And for me, I'm like, okay, like I'm always trying to use Google Scholar or whatever, trying to find articles. And that's hard. Sometimes you don't have access to things. We don't have our school access anymore to articles.
Yeah. And
I feel like you obviously still try to do that, still up to date. There are different journals and stuff you can follow. But a good way really is just reading current concepts, each time it comes out. And, it'd be cool if they could come up a bit more frequently with it. But that's at least the bare minimum is I say at least to stay up to date on that. That'd be a cool way. But yeah, it could be a little expensive too. I think the book is like $450. Yeah. But outside of that, clinical prediction rules,
Yeah, so something I really wanted to talk to you about because I feel like you are so current with clinical prediction rules. So tell us, what is a clinical prediction rule?
Yeah, so a clinical prediction.
He's looking up, just making sure he knows. No,
it is the guideline in which the best combination of medical science symptoms and other clinical findings in predicting the probability, I'm just reading at this point, of a specific disease or outcome are determined. So basically what it is, you have symptoms. People are going to come in with a lot of the, similar symptoms of a condition, of course, look at everybody in a different way, analyze everything. There's not going to be just one person that's going to represent, the exact perfectly, right? So it's just a common cluster of symptoms you may see that might indicate a condition. And in which case, if that indicates that, then there are also clinical prediction rules on how to intervene with that. So they have them for examination, for diagnosis. They also have them for interventions. And so, one of the most common ones, which I'll try to remember off the top of my head, is, doing the lumbar manipulation, right?
Yeah.
And so, I think we will talk about that the most, one of the most used CPRs.
Yeah.
Which is going to be, your typical, like, acute symptoms, less than 16 days, which is really specific. If you have that, like it's a good go on, trying to do at least according to current research.
Which is hard for someone to have low back pain and then to get into a clinic within 16 days.
Absolutely. Absolutely. And I mean, that's the big thing too.
Yeah.
So as specific as that is, so that is something that you can't, use too much, because like hardly ever do I see somebody for low back pain that's within 16 days.
Yeah.
They're going to come after probably trying to see if it goes away on their own within 16 days. And
Right.
then after that, they don't think to go to a physical therapist, right? Because they might go to a chiropractor first, which if it works, it works. Or they might go to, just their primary care, and their primary care will be like, oh, here's ibuprofen or here's medication, right? Which I'm not a huge fan of doing that. I think we should do things a bit more conservatively before we get on medication, and take on that. But yeah, and then they might send them to an orthopedic specialist, like a doctor, an orthopedic surgeon even, right? And hopefully, you have a surgeon that, if not for needing emergent surgery, which, obviously I think, you would.
That's a different category.
Yeah. You know that. Then they would try conservative treatment first before intervening on a surgical level.
Right.
In which case, then you get referred to physical therapy.
Right.
And then,
which is normally about 2 months. I see people who say, oh yeah, I've had back pain for about 2 months. And I ask, what were you doing?
mm-hmm.
Just because I'm curious.
Yeah.
Like, because if I was in pain for 2 months, I would not be sitting around.
For sure.
Absolutely not. But people don't know that there's other options, which is why I love having this conversation of like, hey, you got low back pain. It's here for a couple of days and it's not changing. Go see someone.
Yeah. And, tying in research, the sooner you see somebody, the sooner and better, it'll go away.
Absolutely.
The longer you wait, that's like the biggest thing to talk about in like current concepts. Is like the longer you wait, the more chance you are increasing your chronicity of the injury or the condition, right? So if you intervene quickly, like it's better for you long term, obviously, right? But that is something that we need to emphasize more, is like get in sooner.
Right.
And so, tying into early part of the conversation, we have doctors in front of our names. For what reason? One, because we're able to screen, like how I talked about red flag screening, but two, direct access. So direct access is really cool. And something we had to fight in our profession like a long time to get, is that when you have low back pain and you have for a couple of days, like I'm not saying like you have minor low back pain, like let me rush to a PT right away. Right. But you're like, okay, this is plaguing me. I think this is coming from my posture or, this and, something really orthopedic or whatever. You can go straight to a PT. And they can accept you given that insurance and things are, but either or we can still see you. We can still do a consult. We can still refer you. Yeah. It's important that PTs are seen in the triage, like in that category where you can come in not knowing your symptoms, and we're doctors. You can come see us and we can be like, this may not be physical therapy related. Like we are trained in that. That's something that's really important to know about physical therapists, and that is empowering of our field, because you may come in and you're like, I have low back pain. And I'm like, what's going on? It's like, I've had some unexplained weight loss. They're over the age of 50, right? They're having some constant pain, night pain. They're having maybe even a previous history of cancer, which is really, really specific, right? Maybe familiar cancer. And, they've tried doing things maybe for 4 weeks, conservative treatment, whether it's PT or something else. And all those things aren't working. And then what did I just say? I literally just did CPR or, red flag screening for cancer. Right. So we can come in knowing like, okay, unexplained weight loss, that's really big. You had a previous history of cancer. Okay. I don't even really want to see you until you go get that checked out. Of course we can, still, help with orthopedic things. There's
right. If there's an orthopedic issue.
If there is, right? Yeah. Exactly. Which a lot of times there is. Like, well, like, yeah, my back is really tight because I can't sleep because of the pain all the time. Right. I'm like, okay, well, let me see if I can work with that.
Yep.
But you need to go talk to your doctor, your oncologist. Again, I think you should do that as soon as you can.
Yeah.
And then, which has happened a couple of times in my practice already, where I had to refer out, and then unfortunately it was, cancer. So it's one of those things that, we are good. And the stats behind that, I don't have them, but I could probably find them and give them to you later.
Yeah.
We're really good as PTs at finding those red flags, like over like 90 something percent, like 99%, like good at that. We don't miss those type of things.
Wow.
And so it's important that we see PTs as triage specialists, because you could come in and be like, oh yeah, we can treat you, or no, you need to go, because we are trained in that. And it's important to know that.
And both, like you're saying, great. I'm going to see you for this low back pain that you're having, knowing that there's something else going on. I can help you with this portion. I'm going to send you back to your oncologist to help you with that portion. Please keep seeing me so we can help your pain manage while you're going through what else is going on.
Absolutely. And no matter what, I'm always a resource. And this is how I treat. And I know a lot of PTs are like this too. But it's like you come in, and even if you saw me for 10 minutes, I'm like, oh, you need to go to the hospital, or you need to go here. Like, I'm like, here's my business card. If it's really important, like, here's my number. Like, give me a call. Like, I want to know how everything is. Like, once I start treatment with you, like, I care about you.
Yeah, I'm your
Make
doctor.
sure that I want to see this to the end. I'm your doctor. Even if you don't come see me again, I still want to make sure that you're good. And so that's important to me. It's important to a lot of PTs, which is why it's really cool. Outside of that, I think a lot of PTs do it because we enjoy the connection of being with people.
Yeah.
Whereas, a lot of times, and not to shame any field, because we're all so important in the medical system, but due to insurance and time constraints, other doctors a lot of times don't have the time to build that connection. Whereas PTs, we have the pleasure of building that connection. So, a lot of times PTs pursue that field because we enjoy being around people, and we actually care a lot about people. We're passionate about what we do. And so, if somebody comes in, I'm like, hey, I don't know if you should be here, but please, like, call me later when you get an opportunity. I want to see you. I want to know what happens. And if there's any way I can help or be of assistance or join your medical team in the process, then, let me know, and I'll do my best. So, yeah, kind of way I treat with them.
I love that. So I want to transition and talk about how you use both of these things in practice, because you work in a practice where you do see people pretty rapidly. And so how was knowing the clinical prediction rules and knowing current concepts, how have those two things helped make you so you can see patients on a very efficient schedule?
Yeah. So
talk about like your schedule and how, because bless you, I could not do what you're doing.
I get that a lot. Yeah. I'll say, let's dive into the first part of how I treat it, and I'll connect it to the current concepts
I love that.
of research in CPR. So, all right, just to say what I do. Yeah, I'm an orthopedic and primarily an orthopedic and sport physical therapist. I work at a practice in Irvine, and it's an outpatient practice. And, we accept mainly PPO. And I'll talk about some other things I do on the side, outside of PPO too, philanthropically. But yeah, we see people, every 20 minutes essentially, which is 3 an hour, which is, it's a hard model. It's not easy. And I think people listening to this podcast can, assume the difficulty behind that. It's hard to, when I had first started, I felt like, man, I don't feel like I'm giving enough to each patient. And part of that was because I wasn't, truthfully, like, I'm still figuring it out. I'm a new PT. Like, I'm not as efficient as I need to be yet. And I'm like, I got like 10 more minutes down. I feel like I could have tried this thing, could have done this exercise, whatever it is. But yeah, obviously the time frame behind seeing that. And so in our practice, to dive into it a little bit deeper, I see them personally for, at least 20 minutes, or probably the most I should say is 20 minutes, although I will take more time if I need to. And then we have physical therapy aides or techs that will take them in and run them through the exercise that I will handwrite. And so, a lot of PTs do this. Not every PT does this, but I will, like, most of the time, like, handwrite my exercise. And like, okay, I want to see this based off what I saw with you on the table.
Yep.
Maybe we didn't need to be on the table for massage. Maybe I need to do neuromuscular stuff, like, proprioceptive neuromuscular facilitation techniques or MREs or whatever it is. And I'm like, okay, now let's follow this up exercise. And then I don't always have the time to do that part after I was assessing and then doing some type of treatment. So then I have the blessing of having really good qualified aides, taking them through the exercise that I will hand pick or hand write. I'm like, I want Shawna to do this thoracic extension today because we saw that, she has some hypermobility or thoracic region going into the extension. So now let's follow this up with, foam roll backward, whatever it is, true story.
Yeah, this is real.
Yeah, it's a true story. But yes, and so, and then I'm always eyes on the floor. There are times I'm like, hey, I don't love how this looks. I might, very respectfully step away and like correct something. So it's a hard practice because, you're boom, 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 boom. Right? It's not a lot of breaks. You're going for it. And so obviously the con is like, yeah, I wish I could spend, if you give me an hour with a patient, man, I would love that. And, I do, private stuff on the side, which, we can talk about that.
We're going to slide into your DMs. Yeah.
Yeah. But, where I'm able to get more time. But essentially, through my practice, I don't get a lot of, one-on-one time with the patient. And I still feel like it's very good because of how qualified and how well trained my aides are. I spend a lot of time training them too. And so, honestly, there are pros behind that though. And that's just reps. we all know if you want to get good at something, you got to put in the reps.
Absolutely.
Now, unfortunately, because of, how much we treat, but fortunately we treat that much. So I'm getting patients, boom, 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 boom. And it feels like in this, what are we, 3.5,
Yeah.
going
Yeah.
3.5 years
Yeah.
out?
Yeah.
It feels like I've gained a lot of experience. And
Yeah.
I'd venture to say maybe that more than somebody that is 3.5 years out. So I feel like it has like advanced me in my practice as I've gotten a lot of experiences, good experiences, not so good experiences, but have helped me grow as a clinician. And so I feel like I've advanced a lot quicker because of how many people I treat, how many people I see.
Yeah, you're definitely a phone call for me. When I have a diagnosis that we talked about in school, but I haven't seen, I call Taylor. I'm like, I've read this in a book. I have never helped someone with this condition. What have you seen? And you're like, oh, I've had 5 patients. I'm like,
just today. Yeah.
And I'm like, this is such a rare niche thing. You're like, nah, I see it all the time. I'm like, okay, great. I just haven't experienced this yet. So I really appreciate your knowledge because you've seen so many patients at this point, you've seen so many conditions.
Yeah. And I think this is a good parlay, and I'll come back to the current concepts in CPR. But I think it's a good parlay into, one of those models that I talk about, which is like your evidence-based triangle. I think we all kind of learned that in school.
Yeah.
You have, obviously you have your clinical experience, you have the patient values, and you have the best available research, right? Those are like, that's
the 3 things that you're trying to balance.
You had to balance.
Yeah.
And if you want to treat the patient the best way that you can, you have to focus on those things. And I don't really rank any of them like higher than the other. I think they're all really equally important. If I were to say anything, I'll say patient values. Like, please,
agreed.
Please listen to your patient.
Yes.
A lot of times they will tell you things that
exactly what they want.
Yeah, you could just do it. Of course, there are different things that can confound that, but for the most part, please take all that into consideration. But yes, and then going into the best available research, which I think we should maybe pause there and then tie it back into the current.
I love that.
So yeah, I would say because of how I practice, that has been very valuable for me. That was actually the reason why I pursued the OCS.
Yeah.
It was not for any financial gain or to get an increase in salary, which I think some people may think that's for. No, I just wanted to be a better clinician. And, I don't always have the time to, like stay with a patient and figure things out. Like, of course, I'm getting a lot of patients and I'm like, how can I better my craft and study and be more up to date on stuff? Again, studying for OCS, it's not just about the current concepts of CPRs, but it makes you a bit more well-versed on that. And that's obviously a broader term to talk about just the things that work most for people that, and, it might take you 10 years to figure out. And these are what these expert clinicians are telling you, like, hey, do research in a lab or research in, randomized control trial. This is what this thing is working, systematically. So it's something you should probably at least look at and
consider.
Yeah. And so for me, given that I don't have a lot of time patients, like it's good to know that because I'm like, okay, I can go directly here. Given that, I haven't found anything out through my assessment, I'm like, okay, well, this I'm not picking up, I can use this CPR. They are at least fitting this cluster of, going into, that lumbar, one that we were talking about, right? It was, you have your acute symptoms less than 16 days. You have at least one hip that's, greater than 35 degrees of anterior rotation because we know how much hips are linked to the low back.
Yeah.
You got to have at least one mobile segment, right? One stiff segment, and to know that you're doing manipulation for a reason for the back, right? That's going to help, you obviously have no pain going below the knee because that might indicate something a bit more neurological, right? And you have your fear avoidance behavioral questionnaire work scale, subscale, which is going to be, less than 19, which indicates that, okay, your pain is not coming from a central sensitization or a nociplastic, meaning, your psychosocial factors or psychosomatic factors of your brain is not, making it worse, or that there isn't ways we can intervene there before we give them lumbar manipulation, right? So that's just another example of how connected the mind is to the body, because if you have things like, fear, catastrophizing, kinesiophobia, even depression, anxiety, that can lead to low back pain, and because of, faulty cognition and negative beliefs and things like that. And so those are things we should intervene before we go down this, lumbar manipulation, ideally. So all that to say that, knowing this, I'm like, okay, somebody comes in and they score high on this questionnaire, or they're, having high fear, anxiety, or they're having pain down their knee, or, their symptoms are, far out, which they say you should still probably try it if, they fit the other ones. But yeah, or their hips are like super stiff and I can't get any internal rotation. Like I'm probably going to try working on that before I go down here. But
Right.
all that to say that if they fit those things and I have 20 minutes and they fit this CPR, I'm going to try that lumbar manipulation. And it's probably going to be effective. And so knowing that has helped out my practice because of how frequently I treat. I'm like, now I have the knowledge to like just jump straight to stuff, given that it's appropriate, right? And so, yeah, that's a big thing. And current concepts is really no different because it'll teach you things, again, from just more research. I'm like, okay, well, hey, make sure, talk about this or you talk about that. And it's education. I think I try not to digress too much right now, but being a PT, you have to be an educator first. So it keeps you well-versed on just the body, the anatomy, the physiology behind everything. And I'm a big proponent of explaining to the patient what is going on with them before I even do anything.
Yeah.
And I think that is what current concepts has helped me out with the most is being able to explain to patients on their level and on my level too, like what is going on so they can get a better understanding. And if you can explain that and they get a better understanding what's going on, then a lot of times you decrease those fear avoidance and those pain catastrophizing beliefs because a lot of times people have fear because of what they don't know what's going on. And so being able to properly educate your patient, tell them what you're going to do, what you expect from it, different ways on how to go down different pathways, which is what they teach you in current concepts a little bit too. And just studying for the OCS, like, okay, if this doesn't work, where do you go? You have to have more tools in your tool bag. So it's just broadening your tool bag, being able to explain to your patient things on more levels and being able to quickly and more efficiently get to the solution, which I think is what the OCS has helped me out with most. So.
Right. And I think that made you such a phenomenal clinician because you have this Rolodex in your head. Okay, I'm seeing things that look like this. I'm going to test and prove that to myself that this is what I'm seeing.
Mm-hmm.
Okay, great. Now I know where to go. And then I can give someone else instructions for how to continue to help.
Absolutely. Absolutely. And I'd say like, even just with this lumbar manipulation, right? Like you do that and if it works, like, okay, cool. Follow that up with like posterior pelvic tilts. They say that's like a really great exercise from research standpoint.
Which makes sense.
Right. Because you want to get that pelvis moving. You want to get the lumbar pelvic
Rhythm.
going.
Yeah.
Exactly. So knowing that is really cool. And it's also empowering to the patient too. Like that's not something I knew well enough before I studied for this, that I should follow those things up with that. Right.
Right.
And because the last thing I want to do is create dependence. I don't want my patient to be like, oh, cool, like Taylor's come in, crack my back, and then I'll just do that for once a week for the rest of my life. No.
Right.
I'm going to teach you like, okay, obviously you're not going to do like a self-manipulation like that. But if you do these posterior pelvic tilts and, you follow this up with, whether it's abdominal core or transverse abdominal strengthening, or maybe it's the localizing low back muscles, multifidus, shout out Dr. Benning on the multifidus on that one, all these things to help stabilize, but then keep your lumbar-pelvic rhythm going, and obviously keeping your hips both, flexible but strong, right? If you have glute weakness, it's gonna, maybe we look at firing patterns. Maybe your back's firing before your glutes because your glutes are weak, and then now that's creating more stress to your back. It's just so much. But knowing all that and then getting to it quicker has been probably the benefit of studying these resources. So
I think that's amazing. We're going to switch gears now and talk about the other letters behind your name.
Okay.
The other 4 letters behind your name, which are CSCS.
Yes. So CSCS stands for Certified Strength and Conditioning Specialty, as provided by the National Strength and Conditioning Association, as NSCA. Yeah. That is something actually for 2025 on my goals list that I actually want to pursue more. Truthfully, I haven't implemented it directly as a CSCS, as a strength and conditioning specialist, like for a team or team sports. Outside of just, certain experiences, I haven't signed on or, had a career in that just yet. So definitely take what I'm saying with a grain of salt in regards to that profession, because that's a whole profession that within itself, that there are a lot of great strength and conditioning specialists that, that could do a better job explaining it and doing things like that better than myself. But I like to implement my CSCS within like my physical therapy practice, which has been very helpful. So for me, I always tell my patient, because, obviously the question you should ask your patient, at least somewhere in the beginning or the end, wherever you want to ask it, is like, what are your goals of physical therapy, right? Everybody's going to say, well, I want to be pain-free. Absolutely. That's what we're working towards, right? But how about any other goals? You want to, walk this and you're going to forget that one road in like Europe, El Camino or something.
The Camino. Yeah.
Like this or whatever. What are your long-term goals? I get a lot of athletes too, right? I'm like, oh, well, I want to jump higher. I want to like increase my breath. Like every basketball player I get, it's like, well, after my knee pain is gone, I want to jump higher. And I'm like, of course you do. Like, who doesn't want to dunk, right? And so at that point, I'd venture to say that, of course, there's a lot of stuff we can do within physical therapy to help out with that, but that's probably where my CSCS, my strength and conditioning specialty, is going to kick in. Because now, after we work on things from a medical physical therapy standpoint, maybe again, we're doing stuff from an orthopedic standpoint, we're strengthening
specifically in a very specific
exactly.
region.
Yes, thanks for clarifying that. Specific region, and doing that through neuromuscular training too, right? Like that's where my PT is like, okay, like how about this? We need this to fire. Like I need you to do
appropriately at the right time, coordination, speed.
Absolutely, right? That's a lot of stuff. And, even just looking at a step down, you could break that down like 8 different ways, right? So as a PT, I'm like, nope, this knee is going in past the second toe, right? Or like this, okay, you get like C femoral, the hip dive, kicking in a little bit, like that's creating this. Or man, your feet are caving in, or you have no dorsal. Like there's so much to look at, right?
Yeah.
That's where our PT is coming in. But once we get that down, and I feel like your mechanics are good from a very foundational standpoint, which is more the physical therapy, then I'm like, okay, now we need to kick things up. Because at that point, I think this is where a lot of PTs maybe miss the mark, is they're like, okay, cool, yeah, go back out to sport. I'm like, whoa, you didn't test them in any other way. Like, did you do any agility tests? Did you do any strength tests? And, I use a Evolve system, which I think is a conversation for another time.
Okay, we'll put a pin in it.
But, I'm doing objective testing, but I'm also pushing my patient an extent of like further strength and conditioning, because we worked on things foundationally, but we didn't get them back up to speed for sports speed. So that's where my CSCS kicks in. So I'll use my knowledge of that with different exercises, different strength and conditioning, working on speed, agility. I mean, I don't even know.
And I would just say injury prevention, right? Like there's a reason that they got hurt, likely, probably because they weren't strong enough in something, right? So now we've corrected the strong enough in one place, but how does that fit into the big picture of their whole movement system? Okay, great. Now I feel like that's when you use your CSCS, is how do we make their whole movement system efficient so that they don't have to come see you, right? Like how do we prevent future injury? I think that's a big thing that we don't often talk about, is prevention. It's something that I'm really passionate about. I know you are too. Is like, I'm so glad you're my patient. I would love to never see you again. Here's how we do that.
Absolutely. No, I mean, I think this is one of the very cliche things that we talk about as physical therapists, but something I say too often probably, but my job is to put myself out of business. Like if I did my job right, then hopefully, knock on wood, barring like an unfortunate circumstance or injury or traumatic injury, like it's sport, it's only so much you could be prepared for.
Totally.
But hopefully I don't have to see you again. Or if we do, like, hey man, maybe I'll walk into the grocery store. I'm like, how's everything? And oh, man, too, everything's so great. I'm like, it's like freaking does it for me, right? That's why I want to see you. I don't want to see you in the clinic.
Right.
If a patient does return, which occasionally happens, like we all have that.
Yep.
The first thing that crosses my mind is like, man, right? Like I feel like, okay, man, what did I? Like I'm maybe a bit personalizing that a bit too much, but like, what did I?
Did I miss something?
Did I not work on prevention well enough?
Yeah.
Did I not connect that pathway? Because again, like I was saying, is like physical therapy, good foundation. Boom, we shoot them back to sport. But then the strength and conditioning is the bridge to me on how to get them back to that more efficiently, but also from a preventative standpoint, like how you're talking about. Maybe I didn't work enough on prevention, and more so than anything, it's usually come back because they have a different injury from a different way, right?
Yeah, something happened.
Something else happened. Yeah.
Yeah.
So thankfully, that's been the majority of my experiences. That being said, yeah, it's been fantastic. I think that's helped me with my sport physical therapy, and significantly strength and conditioning. Usually, a lot of PTs in my clinic are like, "Well, that's the best exercise." And I'm like, "Well, one, I use that strength and conditioning specialty, but I'm really big about doing that from a neuromuscular standpoint too."
Absolutely.
And shout out Dr. Demars. I'm going through our teacher catalog right now, but I'm big on like the principles of neuroplasticity. Like I'm not going to say all of them right now because I'm like recite them, but I'm big on task specificity.
Yeah.
Making it salient for the individual. That way that it's enjoyable, but it's replicating the task.
The activity that they're going to do.
Mm-hmm.
Yeah.
I think as PTs, we all know like the set principle, right? This specific adaptations impose demands, right? You need to put them in situations in terms of the environment of the sport, like speed wise. Like we might do a shadow drill, right? Where I'm like, okay, you have to match me. It's like Simon says, like if I shuffle right, you got to shuffle right, and like shuffle backwards, you got to match me, right? So that way you're creating a perceptual cognitive factor, a reactive stimulus that in sport you need. Like it's always going to be a defender, in most sports, right? It's something you're always going to have to react to. Like, are we doing that as PTs?
Yeah. Is your reaction time good?
Yeah. And I use blaze pods. I do whatever I got to do to do it. And I'll do it in a setting that might even just say, hold this basketball. Even if it's not doing anything, it's too specific. I'm like, while I have you balance on this, I'm working on your proprioception, your balance and coordination, things like that. and having you balance on Eric's pad, doing like a tree matrix or something, so it's a bit more dynamic, testing your limits of stability. I might have you just hold a basketball, just cause like, it's going to be salient for you. I'm going to make more fun of you. I mean, it's just, you're going to want to do it. But at the same time, it's tapping into something that might translate to the court too. There's going to be times where you're going to need to be on one leg and contort your body to try to get right.
To do something, yeah.
Exactly. So using those neuromuscular principles to be able to tap into sport, I think that's what I've used from the PT and from the strength conditioning specialty. And then you try to do that all for hopefully the prevention of people coming back in. So yeah. And I know you want to talk about a little bit about prevention as well.
I do. Yes. Tell me.
Yeah.
So, and I want to make a comment on that too, because I see a lot of older adults and they'll tell me, I don't understand why I need to do squats. And I'm like, do you plan on getting up and down off the toilet independently your whole life? Do you plan on getting up and down from your kitchen table independently your whole life? And so I think no one has told them that a squat is standing up and down. Mm-hmm. And I think that for me is how I help people with prevention. Like in a non-sports way, right? Life is a sport, but I think if we're like going back to general movement concepts, okay, I'm preparing people to get up and down off the toilet for the rest of their life. Like that's huge. Like when you lose that ability, that completely changes your life. So I think that's also something that I know you do as well. Is like, how do we take in a sports way, but then in a life way, how do we tell people, okay, these movements are important for the rest of your life because you want to be able to move independently your whole life.
Yeah.
And no one has told them that.
Yeah.
It's amazing.
It's amazing. Yeah. And I love that how you said the getting up off the toilet. It's like, oh, I don't squat. I'm like, well, do you sit on the toilet and stand up? Like, yeah. I'm like, well, you squat.
You do.
That's something that we see all the time, right? I was like, I haven't squatted in years. I'm like, well, did you use the toilet today? So you did. Or did you sit on your bed and stand back up? Did you sit in a chair?
Did you get in a car?
Did you get in a car? Right? Like, man, getting in the, for all the patients I've seen from low functioning to high functioning, man, getting in a car is not easy to do. Yeah. In any situation. Like I have a patient who's struggling from lumbar radiculopathy. So, pain around the nerve leaving the spine, right? And he has such a hard time getting out of the car. And man, he's 36. So, it puts things in perspective. Like there are things that just remind you how hard things are. And a lot of my patients, that are recovering from surgery, like knee patients, I'm spending so much time doing gait training, teaching you how to walk. And shout out to one of my patients, obviously I'm going to go into it, but she was like, man, I don't remember how to walk. Like, why is this happening? And I'm like, hey, I'm here for you. We're working on it. I'm using hurdle training. I'm doing things. And she was so perplexed at like her inability to walk after, one surgery.
Yeah.
And it was a quick surgery and came out just your body, just kind of the mind-body connection, right? Again,
absolutely.
Tying it into the beginning part.
Absolutely.
That's like, your brain, like some of those connections can go dormant, right? Tapping into neuroplasticity. And so it's one of those things that like we do a good job at waking that back up and then even refining it and teaching how to do things maybe in ways that you haven't done before. And that's good for prevention as well. Like shout out Dr. Stina, man. I'm really, like I'll say, Mom, you're welcome for the plugs, man. No, but who's that one day she came into class and she was like, did you guys get the book? Did you guys get the book? And I'm like, what are you talking about? It's like, did they give you the book of how to walk when you were young? Yeah, right? Like, oh, okay. There's another Dr. Spina.
She's just about to go there.
Yeah, and I love her, man. She's so great. And I'm like, yeah, nobody gave us the book of how to walk, right? We just learned that through our own development, the mental patterns and things like that, and milestones. And sometimes that may persist, and you might pick up abnormal biomechanics that persist in your life, and that can affect you later on. And so we do things to, obviously teach you how to do things again if anything happens, but also refine movements to prevent other things from happening in the future. Like, one thing we should be doing and tapping into, again, the topic of prevention, I think the national recommendation for steps per day for like a healthy individual is 8,000 steps per day. For me, that's a really big thing. And when you look at like the monogram from Current Concepts for low back pain, they talk about, so like in that monogram, I don't think they talk a lot about the specifics of like the orthopedic low back pain. They dive into a little bit about like, oh, you might have, motor changes in a disc, the spine. Obviously disc, they talk about certain orthopedic structures, but most of that monograph is like, okay, hey, there's so much centrally that can cause low back pain, so you should be intervening with this. And even emphasizing like Tai Chi and yoga, things that, you do.
Yeah.
Shout out to this podcast, Authentically Shawna, right? Like you're talking about the health and wellness from multiple perspectives.
Yep.
That's really big. And low back pain, you can tackle that by having a healthy lifestyle. And that's really big. And one of those things they talk about in a monogram is getting 8,000 steps per day and how that is linked to decreasing low back pain. And you would think, like,
Which is crazy.
it's crazy because people think that movement is going to, like, hurt them because they're upright for so long. And of course, there are different circumstances where that may not be the best at that time.
Right.
I emphasize at that time.
Right.
I'm not here to create fear avoidance or kinesiophobia.
Right.
Like, the goal is always to get you back to walking. Maybe it may not be the time right now, but we're getting there, right? Like, I'm never going to be like, oh, never. No, we're not. We're just going to refrain from walking.
We're going to skip walking.
Yeah.
The rest of your life.
Yeah. And I got to get you back to 8,000, right? And so that is a good thing to do for prevention, is getting 8,000 steps per day. And just to keep it very general, outside, obviously, of like your traumatic circumstances.
Right.
I tell people, man, like, if you just walked every day, you did some yoga a couple of times a week, and like, I do yoga with Adrian. Like, shout out Adrian, that's my girl, right?
Which is on YouTube, right?
It's on YouTube.
Yeah.
Very accessible.
It's free. Yeah.
It's free. You sit through like 2 of those ads. YouTube's getting a little crazy with their ads in the beginning. Sit through a couple of those ads. She puts on series all the time, like, 20, 30-minute episodes, and just get you moving and working your flexibility, and mobility, and things like that. And so do that a couple of times a week. It doesn't have to be a full hour. And, shout out Yoga on the Bluff.
Yeah.
Love yoga.
We live in Long Beach.
Yeah, we live in Long Beach. Sorry. Bluff Park in Long Beach, off Ocean, right? Right by the water. And I think that's a really great thing on multiple, facets, in the sense that you're doing yoga in the park. It's free, but you shout out, give a couple $2 to instructors. They're just time of their day.
You're getting earth on your skin.
Exactly. Getting earth on your skin, right? But there's a huge benefit of environmental therapy too. You're getting outside. You're breathing the air. You're getting sun. Sun is great for our skin, right? It's good for a lot of things. Like vitamin D, they say is really good on a lot of physiological levels.
Yeah.
Right. I think if you listen to anything about, like, any Huberman podcast, he's going to talk about getting outside.
Vitamin D. Yeah.
Like,
Get your vitamin D.
I think he talks about, like, get outside and sleep. And that's like his biggest things. And right now I think he's talking a lot about like zone 2 cardio stuff, which I'm not going to get into. But yeah, it's important that you get outside and do stuff like that. But that you're moving, and just moving in general, keeping that going, working your flexibility, your mobility again. That's really good preventative. So I say get your steps in, do a little bit of yoga from here and there. If you can get outside, great. And a couple of things, and I think it's really important to do resistance training.
Yeah.
And that comes from both my PT and my CSCS, my strength and conditioning, because resistance training, like, shout out Dr. Dawson. I couldn't
You could leave her out.
I couldn't leave her out when I do this podcast for sure. Man, she's so fantastic. But like, sarcopenia, we learned a lot of that from her classes.
Define.
So sarcopenia is age-related muscle loss, which that happens, right? And that's what you talked about before from a preventative standpoint.
Mm-hmm.
Like, if you don't do anything, you don't use it, you lose it, right? When it's cliche things you're saying, but it's very true. And sarcopenia is like the physiological way of telling you if you don't use it, you lose it, because just by aging, you will lose muscle, and it starts to convert from different types of muscles to, those that aren't as strong, don't move as fast, exactly, fast twitch, you can't lose that. And so from PT, even if you're not having pain, like, we could prevent those things from happening, metabolic syndrome, things like that, which includes your triglycerides, your blood sugar, your measurements, your belly fat measurements, and things like that, your waist circumference. And it takes all those, and your blood pressure takes all that consideration. PT is good for limiting metabolic syndrome and sarcopenia. And there's so many different ways to do it. You could do group exercise. You can do, individual. You can tap into Tai Chi. And shout out, I'm going to bring in different things. I read a book called Ikigai. I think it's like the Japanese secret to a long, happy life. And it teaches you how to have purpose in your life. And one of the biggest things that book talks about is community. If you have a hard time, like, doing exercise, and that's an obstacle for you, like, individually, find people to do it with, and find them on your level, or find someone that's just understanding, and I think you'll find that most people are understanding no matter what. Like, we have the fear of like, oh man, if I go to the gym, or if I, join this class, everybody's going to be so advanced, they're going to think less of me. Like, that's mainly in our heads. But
no one's watching.
No one's watching. Let's do the best you can, and that being said, there's a huge thing that we could tap in with community and group exercise that, again, shout out Dr. Dawson. She's been doing research on. And that's been very beneficial for people. Like, I had a private client that we were working well, but they just couldn't seem to do some of the stuff I was asking them to do individually outside of our one-on-one sessions. Right. And I recommended group exercise, and they've been doing better with them than with me. I got to got to call that out, right?
Totally.
And so some things are just different for different people.
Absolutely.
And just knowing that there are many options with exercise and physical therapy, not only from the different specialties we talked about. Now I'm kind of tying in the whole podcast.
Thank you. You're the best.
Not only from the different specialties we talked about, from cardio, pulmonary, and neuromuscular, and oncological, and all those things, but also just from the different areas we can work with in exercise and do things like that. We can do so much, and we can do group exercise and in physical therapy settings and all those type of things. So having a good sense of community is fantastic. If it helps you get over your fear of moving, by all means, like, that's fantastic to do. And again, shout out that yoga on the bluff, because that has all of it, right?
Yeah,
You're moving,
absolutely.
You're working a little bit hard. Some of those positions are a little challenging.
Yeah, absolutely.
You're outside in environmental therapy, and you're out there with, what's it, like 60, 70 people
Yeah.
on a good Saturday, right?
Yeah.
So, and those are all great ways to prevent things from happening, and preventing that muscle loss, preventing, your cardiopulmonary system from decreasing its capacity, and ultimately limiting, preventing you from being in a nursing home. That's one of the things we're always so fearful of as we age. Like, I don't want to be in a nursing home.
Yeah.
And I think there's stats, like J-Rod talked about in one of his classes, that talk about like balance and like lower extremity strength being like the indicating factors, like the most not implicating whether or not you're going to end up in home one day.
Yeah.
And maintaining that lower extremity strength and core strength and balance is really important for prevention. And that's why I say, walk, do your yoga, pop a couple squats per day or something.
Please.
Do some squats. I could go into prevention in a lot of different day-to-day things, but like, if you work a sit-down job, please stand up like a few times an hour.
Every hour. Yeah.
Hour. I'd like to say stand up every 20 minutes.
Yeah.
Like 3 times an hour. And I'm kind of stealing that from like the optometry rule, right? Whereas
Yeah.
20/20 rule, like if you're staring at a computer for 20 minutes, look away for like 20 seconds. Like 20 feet distance.
Mm-hmm.
But I'm going to steal that and add in the PT component. Go walk outside for a little bit.
Go look out.
Just
in a distance.
Go look
do
at
some standing marches.
If you can go out, if you could just walk out your door, stand outside, do some spinal twists, given that's okay. And just, do stretches, maybe just do a couple squats, like 10 squats outside, come back and sit back down if you need to. I have a standing desk and I like to stand do my stuff.
Yeah.
But, given I know people have meetings and stuff, so obviously do the best you can, like hour meetings, but moving, that's really big. Like this idea of prevention is just please move more, like within your capacity. And that's a really big thing. So.
Thank you so much. This has been so insightful. If someone would like to work with you, what's the way that they can do that?
You can reach out to me on IG, for maybe those who are social media inclined. So my IG is Tay Silks.
Put it in the show.
Put it in the show notes. TaySilks. And I'll give my email too for those who are less, social media inclined. But Sillekens at gmail.com. And then we'll put that in the show notes too. So
okay.
Yeah.
Thank you so much. If anyone has more questions about injury prevention, don't worry. This is not the only episode that we're going to be talking about this in, because I think it's so huge. I love what Taylor had to say about that. I think I sometimes forget to tell people you don't have to do the same thing all the time. Like, variety is the spice of life. Thank you for reminding me. I need to get better at reminding people to have variety in their movement. And it doesn't need to be just one thing constantly, but to have variety in what they're doing to prevent injury. So thanks for that, Taylor.
Absolutely.
I'm going to wrap us up. You've been listening to Authentically Shawna with Dr. Shawna Burke. The information contained in this podcast is provided for information purposes only and is not intended for the purposes of diagnosing, treating, curing, or preventing any disease. Before using any products or techniques referenced in this podcast, consult your healthcare provider. Opinions of guests are their own, and this podcast does not endorse or accept any responsibility for statements made by guests. Individuals on this podcast may have direct or indirect financial interest in products or services referred to herein.